started 2 minutes time. Okay. Started my timing. Hello, I'm Dr. Prajakta, one of the Part 3 MRCOG candidate, and I am ready for structured discussion.
Can you please summarize the?
Yeah. So in this case, I am working as a ST5 labor in labor ward, and I'm having a patient, Mrs. Rachel Brown, who is primary gravida, 31 weeks of gestation, presented with abdominal pain. So I am suspecting a diagnosis of preterm labor, since patient is having colicky pain and renal angle tenderness secondary to urinary tract infection, could be associated with urinary tract infection. So far as the patient is low risk, uh, and there isn't any significant history has been given in this case. So this is my summary.
Justify any additional clinical examination that you would like to perform.
Yeah. So, in a suspected case of preterm labor, where the patient is primary gravida, 31 weeks of gestation, presented to the emergency, I would like to take initial information from the patient and the midwife after introducing myself to the patient and midwife regarding the onset, duration, and progression of symptoms. Uh, Associated, although it has been mentioned that it is a colicky type of pain, still whether it is hardening continuity, I would like to ask that history. It has been mentioned that there is no bleeding or fluid loss and the fetal movements are well appreciated, but still I would like to take another other history like drug abuse, smoking, and any history of trauma or fever. Along with that, I would like to take a medical and surgical history. If it surgical history has not been mentioned here, mentioned that there isn't any scar, but medical history which has not been mentioned, so would like to take that, and offer patient examination in the presence of chaperone to confirm her vital parameters, especially pulse, blood pressure, temperature, respiratory rate, to see the hemodynamic status, because in cases of abruption we might get high blood pressure or a hypertension. So I would like to take that, and per abdominal examination to see sympathy of fundal height is corresponding to the period of gestation, fetal heart rate, uh, uterine activity, uh, and if possible, I can offer this patient a continuous fetal heart monitoring assessment meanwhile, and would I like to offer intimate examination, pervaspeculum and pervaginal examination in the presence of chaperone to see the cervical status of the membranes, dilatation, and if possible, presentation and station. So this is my clinical information, and would like to offer certain investigations in this case. So shall I go ahead with investigation or shall I stop here?
Now I'm telling you findings. The uterine
Okay.
contractions are occurring every 10 minutes and they are moderate in strength. And on pervaginal examination, cervix is fully effaced but 1 centimeter dilated. So, what is your differential diagnosis? What investigations do you want us to perform?
Yeah. So, with these clinical findings and history of presenting complaints, my most common or first diagnosis will be a case of preterm, idiopathic preterm labor. But here, still, I would like to rule out other differential diagnoses like any obstetric condition like abruption, any gynec conditions like colitis, uh, acute appendicitis, or renal pyelonephritis. So this condition I would like to rule out by doing blood investigations, especially full blood count, urine, midstream, CRP if WBCs are raised, vaginal swabs, and ultrasonography, especially to rule out abruption. Although it is not having that much sensitivity, but still I would like to rule out. Then presentation. And estimated fetal weight of the baby I would like to rule out from you, and cervical length through TVS. So these are my investigation of choice in this case.
Okay. On the assumption that the most likely diagnosis is idiopathic preterm labor, what initial management will you arrange? Few reasons for your actions.
Yeah. So in case of diagnosed preterm labor, I would like to offer this case admission under consultant-led care unit. Here, I would like to check whether the place is there available for an ICU in the for the baby, and inform the neonatologist and inform the consultant here only while admitting this patient. Uh, the next thing will be offering this patient, after assessing maternal and fetal well-being assessment, would like to offer this patient a management for preterm, idiopathic preterm labor that will include stocolysis, steroids, magnesium sulfate, and IAP if she goes in labor. So neuroprotection and IAP will be offered to this patient if she goes in labor. Steroids will be in the doses of injection betnazole, 12 milligram, two doses, 24 hours apart for lung maturity or lung protection and prevention of RDS, and magnesium sulfate if she goes in established labor, then it will be offered in the doses of 4 gram IV slowly over 15 minutes followed by 1 gram IV per hour for 24 hours for neuroprotection. So if she goes in labor, then that will be offered to this patient. Tocolysis in the form of calcium channel blocker, although it is not licensed, but this needs to be offered to this patient. Initially 30 milligram starting dose followed by 10 to 20 milligram QID will be offered till steroid acts. And lastly, it will be IAP, that is injection 3 gram benzyl penicillin for the prevention of GBS prophylaxis, and followed by 1.5 gram 4 hourly for 24 hours. So this will be offered to this patient. Patient will be admitted. Patient and the mother and the baby will be observed continuously for progression and halting up preterm labor.
Any, what about the pain relief? How will we counsel the patient?
Yeah, I couldn't able to mention, but after admission, I would like to explain the patient the importance. I mean, I would like to check her background knowledge regarding the preterm labor, uh, and I will explain her what is preterm labor and what are the implication of preterm labor on mother and baby. On mother, it will not have much impact, but on baby, there will be short-term implication and long-term implication. Short-term implication will be RDS, then sepsis, an ICU admission, and long-term implications will be having delayed milestones. Sometimes CP is associated with all those things. So that all I would like to explain to the patient.
3 years later, the pain gets much worse, and the CTG now CTG is pathological, and she's found on examination to be fully dilated with the head occipital anterior at cluster.
Okay, so now the patient is in established preterm labor. So here I would like to stop tocolysis, whatever I have started initially. In view of pathological CTG, I would like to rule out any acute event if it has been there. and offer patient a corrective management in the way in the form of analgesia, IV fluid, hydration, repositioning, and see to it whether it is getting corrected or not. If it is not getting corrected, then expedition of labor is indicated here. This needs to be informed to the consultant and the theater team and the pediatrician and the labor team for regarding the instrumental delivery. The safest modality will be a forceps delivery in view of preterm labor. Consenting will be done. Consenting will be taken. Patient forceps will be applied in the in the labor room only. Ensure that adequate analgesia will be given to her. Consent, bladder catheterization, apply forceps appropriately with the help of episiotomy, deliver the baby safely, handed over baby to the pediatrician, cord blood assessment of this patient, cord blood pH assessment of these patients. Active management of third stage of labor needs to be offered to these patients to prevent the PPH, assess for trauma, assess estimated blood loss, assess any fourth and third degree perineal tear. If there are tear or episiotomy, sutured accordingly. Swab instrument counts needs to be taken care, and this needs to be documented in patient's case detail. In view of forceps delivery, we can offer this patient antibiotics prophylaxis, bladder care, and patient will be debriefed, documentation, assess the risk of DVT, assess the risk of DVT, and DVT prophylaxis of needs to be offered to this patient. So this is what we need to offer this patient at this point.
Do you want to add anything now?
Time up. Did I missed out anything?
The future pregnancy, any advice regarding?
Okay, yeah. So once the patient will be stable enough, started or moving around orals, and ensure patient can be discharged to the primary care with the advice of contraception, uh, and counseling regarding next pregnancy. Counseling regarding this is a traumatic event for the patient, so patient will be offered a support in the form of support group. Patient will be offered a written information regarding preterm labor, uh, and patient will be offered a counseling if needed to the patient, and guidance regarding future pregnancy will be discussed with the patient. Meanwhile, patient can be offered contraception.
Ma'am, anything regarding this cervical length assessment in the future pregnancy, ma'am?
In view of current preterm labor, the patient will be offered a serial ultrasonographic evaluation of cervical length from 16 weeks onward, and patient will be offered a consultant-led care booking in view of this current pregnancy.
Okay, ma'am. So well done, station, ma'am. Super.
Yeah.
But pain relief alone, I have forgotten, ma'am. Everything.
Analgesia I mentioned.
Yeah, yes, ma'am. Yes. Okay.
Okay. Yeah. So this we have recorded very nicely. Thank you, ma'am. So
Thank you,
any
ma'am.
feedback on this thing? Otherwise, we will go through the answer key.
Yeah, the introduction was super, ma'am. I mean, you were telling about the explaining or summarizing the scenario also. Then about the differential diagnosis also, you have explained very well that it's you have to rule out abruption, the preterm labor, and a urinary tract infection and acute appendicitis, all, and any trauma, everything. And in the history also, you asked about traumas, any cause for preterm labor, like smoking, drug abuse, everything you asked, ma'am. And about the infection screening also has been done. And the patient also, you advised admission, you offered admission, and you counseled the patient and offered the pain relief also. You informed the consultant and the neonatologist, and you checked for the NICU cot availability, and examination of the patient also to rule out abruption, about for giving the tocolysis, and the dosage of the medications, and max self once the labor if it is inevitable, and I mean intrapartum antibiotic prophylaxis also, everything you explained, ma'am. That also checking allergy and explaining everything to the patient and the implications also you explained. After that, the as the labor progressed, you stop the nifedipine. That's a very good point, ma'am. And as she was on nifedipine, you have given the active management of the third stage also, and delivery by after getting consent, the forceps being done in the labor room after getting consent, the verbal consent. And it was done. Then you told about the catheterization and the care, bladder care, documentation, debriefing the patient, and the care of the baby by the neonatologist and the cord blood sample, everything, and BTE risk assessment, everything you explained, ma'am. Even the contraception, all you explained. It's a very well performed station, ma'am. Thank you, ma'am.
Okay. Thank you, doctor. Thank you for helping me out to record this station. So let's go through the answer key. Okay, what I have presented.
Okay.
So the first question, summarizing, was a very nice question, what you have asked. So when it comes to summarizing, I would like to request all the students who are appearing for part 3, do not read the information, whatever has been given. Whenever you are getting a time of that 2 minutes, if there will be lengthy information, at least write down the bullet points, identify the scenario and identify the situation. So looking at this situation, you can very easily make it out that it is a preterm case with a low risk patient. Okay. So at least summarization, that means you just need to give a small summary or small brief points from that scenario to the examiner. So this is actually a S-bar pattern, but in summary, it will be a Mrs. Rachel Brown is a case of in view of her presentation, since the patient has been presented at 31 weeks of gestation with acute colicky pain, I am suspecting a preterm labor. And apart from that, the patient is not only significant history is here, renal angle tenderness, and no further high risk factor has been mentioned here. So this much information is enough to summarize your task. Okay, so do not read it out. Reading is, you will be lacking on your marks, so do not read it out. Okay, now coming to the first question, what madam has asked, justify any additional clinical examination. Answer. So in a suspected case, so wherever you are wanted to present a case, you have to follow SBAR tool. Suspected case of preterm labor in view of colicky abdominal pain with a background of primary gravida 31 weeks of gestation corresponding by dates and clinical examination, low risk pregnancy up till now. So its assessment includes nature of pain, continuous spasmodic heart, nausea, vomiting also. Okay, trauma, smoking, substance abuse, fever history is also important. Okay, examination, general examination, you need to in structure discussion always justify why you wanted to ask history, why you wanted to ask examination and interventions. So general examination, especially you would like to rule out abruption by ruling out blood pressure and tachycardia if it goes in favor of hypertension or hypertension, and per abdominal and per speculum per vaginal examination you have to mention the FHR, you have to mention the type of contractions, whether it is stony hard or whether it is intermittent. Then per speculum per vaginal examination, cervical status, length, membranes, and if possible presentation if you can feel. Otherwise, it's a very soft part at this point, may not be may not able to do it. I have mentioned investigation here, but then there was a next question. So let's go through the next question. Uh, Uterine contractions were occurring every 10 minutes and the good strength on vaginal examination fully effaced 1 centimeter. What are your differential diagnosis and what investigation would you like to perform to reach the diagnosis? So preterm, my differential diagnosis, the first and the foremost diagnosis here is preterm labor, but I would like to rule out other diagnoses like urinary tract infection, pyelonephritis, cystitis, abruption, non-obstetric or non-gynec causes like colitis and appendicitis. Investigations will always be according to the NICE guideline, full blood count, CRP. CRP, I think I have not mentioned. If WBC count is high, then only you can say CRP. Otherwise, you would like to rule out the causes for preterm labor. So rule out infection by sending a swab, midstream urine, ultrasonography, including KUB, and OPS ultrasonography. Okay, so OPS ultrasonography for TVS for cervical length and fetal assessment, especially presentation here, and abruption, ruling out abruption. Although abruption sensitivity to rule out abruption by ultrasonography is less, but you need means at least you can say if patient is hemodynamically stable, then only all these investigations will be ultrasonography will be rule out abruption. Cervical length less than 15 centimeter is goes in diagnosis of preterm labor. Next question, assumption that the most likely diagnosis is idiopathic preterm labor. What is your initial line of management? What initial line of management will you arrange? Give reasons for your action. So, admit, check an ICU, assess and continuously monitor this patient. Here only you have to communicate with the patient. If it is in structured discussion, if the communication with patient domain comes up. So here you have to explain to the patient what you are suspecting in her case, what does that mean to her, and what does that mean to her baby. So that is communication with patient in structured discussion. Here that domain has not been tested. So okay, but communication with patient is important per se when it comes to patient safety also, because what patient is undergoing, we need to explain this to the patient. So explaining her about preterm labor, short term and long term consequences, implications, assessment continuously of fetal and maternal well-being, and stress all baseline blood investigation. What you would like to give her: steroid, tocolysis, neuroprotection, that is magnesium sulfate, and GBS prophylaxis, and continue fetal heart rate monitoring and watch for progress of labor. Here, if halted, patient can be shift means discharged after the treatment of preterm labor. Okay, but if it progresses, then we may have to conduct a labor or conduct a delivery. So next question was, the 3 hours later there was worsening of pain, CTG was pathological, patient was fully dilated, and occipito anterior 2 centimeter below the ischial spine. That means it was a where you can apply forceps in the labor ward. The chances of failure of this progress is forceps is less. Stop tocolysis as she is in established labor. That should come to your mind first thing. It is one of the important patient safety point. Allow labor to progress. Presentation of fetus to decide MOD. Oh yeah, this point I missed, doctor. Okay, this point I missed. So if it is a vertex presentation, then only we will continue with the MOD. If it is a breech presentation, then it will be going for
Cesarean.
cesarean section. Okay. Fetal, at least you may have to explain to the patient both the options of imminent vaginal delivery and cesarean section. Fetal heart rate monitoring needs to be continued on FH CTG. Since pathological, you need to rule out acute event. Acute events are here, there is no chance of rupture, but rupture will be less likely. You have to say this way, rupture will be less likely. Abruption and cord prolapse, these are the two events which you can expect here. Corrective measures like fluid and analgesia, repositioning, need for instrumental delivery, forceps, not ventus since preterm. Okay, she is preterm in labor. Analgesia, most of the time it is pudendal block. Catheterization, consent, theater and anesthetist will be alerted here. Consultant will be in loop. Pediatrician will be called upon. Define station, assess need for episiotomy, safe application of forceps, or since vacuum is contraindicated, cord blood sampling, neonatologist assessment after the baby delivery, assess episiotomy, third and fourth degree perineal tear, suturing. Okay, although I had not mentioned, but that means suturing of the episiotomy and third and fourth degree tear if it is there, estimated blood loss, swab and needle count. Okay, that is one of the important point which I had not mentioned here. Active management of third stage of labor, document debrief breastfeeding support, PIL of preterm and support group, that is early bliss association or bliss association, early birth association or bliss. These are the two important support groups for preterm labor. Patient can be discharged after criteria made for discharge with further precaution for her next pregnancy and contraceptive advice. That is what I had mentioned here. Okay. So if we see a domain wise scoring, so broadly we will be communication with colleague. So here are two: communication with colleague. So how you are going to go in a structured way and presenting your scenario to the uh, examiner, that is one way of communication with colleague. And the second communication of colleague will be whom you will be informed here. So the people who will be involved here will be the midwife or a labor staff, pediatrician, who is very important, not to forget about pediatrician, and thirdly theater and anesthetist team. So these are the communication skills what will be tested in this domain. Then next is applied clinical knowledge. So the applied clinical knowledge will be diagnosis, reaching a diagnosis by the clinical scenario, giving a differential diagnosis to the patient, okay, to the consultant or to the examiner. uh, and it should not be prompted by the examiner, okay. If more prompting will be there, you will be losing on your score, okay. So minimizes your prompting. uh, what information you would like to know to reach a comprehensive diagnosis of idiopathic labor, urinary tract infection, abruption. Investigation. So here offering an investigation like midstream urine to rule out infection, CTG and ultrasonography to look for signs of abruption. Having reached correct diagnosis, they will further demonstrate their applied clinical knowledge in giving a evidence-based management plan, including steroid, tocolysis, try to arrest a labor, and this will be also coming under patient safety domain. These points will be steroid and neuroprotection will come under patient safety domain. It is important to note the third examiner's question, the uh, word initial. Okay, so what does initial means? Initial means always the basic stabilization of the patient. Okay, basic stabilization of patient is initial line of management. Information gathering, whatever has been given, interpret that information, then ask the relevant information here, ask information in the form of clinical examination and investigation. That is all being involved here in information gathering domain. Patient safety, stop tocolysis immediately. Prepare woman for delivery when there will be pathological CTG, that is by ventus and not by that is by forceps and not by ventus. Yeah. Analgesia, good analgesia, perineal infiltration by pudendal block, if you can remember this. And competent candidate will able to describe examinal why it is inappropriate to delay labor by offering a fetal blood sampling. Okay. Anyway, she is a preterm labor, fetal blood sampling would not have had been offered. And nowadays the new guideline doesn't support this. Okay. And why not cesarean? Why not cesarean section? Because she's already fully dilated and station is at plus two station. So we can very safely apply the full forceps here. And this is reflection on the task. Review the notes you are made before reading the examiner notes. Communication with colleague, acceptable use of medical terminology. Avoid layman language when you are doing a structured discussion, because that is again tested in your communication with colleague domain. uh, Justify the keyword. It will be vaginal examination and per speculum per vaginal you have to say, not only VE. Clinical emphasis on clinical examination. There is no credit of mentioning fetal fibronectin. Okay, you must be stopping tocolysis as early as possible. This is one of the commonest tasks, and you have to involve the neonatologist at an appropriate steps. Okay, so this is what the whole task, what we have discussed right now regarding a labor module. Okay, so I will stop recording.
Hello.
Yes.